Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EuroTimes. I'm Sean Henahan. Allergic keratoconjunctivitis is a therapeutic challenge in the pediatric population, even more so in atopic patients. Today we will be discussing how to approach the diagnosis and treatment of these patients with Dr. Dominique Bremond-Gignac of Neckar University Children's Hospital in Paris. Welcome.
Thank you.
You presented at a session on ocular surface disease on the subject of atopic keratoconjunctivitis in children, a topic you covered in a recent issue of the journal Ophthalmology. Tell us about this presentation in young patients.
Well, of course, this is very interesting because usually we say that atopic keratoconjunctivitis is just for adults. And also when we have severe ocular allergy, we think that adults is atopic keratoconjunctivitis, and in children is supposed to be vernal keratoconjunctivitis. But we know also that some of the vernal keratoconjunctivitis just turn to atopic keratoconjunctivitis. So where is exactly the link? It is important to know that. And so we find out that some of these children with theoretically vernal keratoconjunctivitis had also something else, which is atopic dermatitis ongoing. So when we have children with severe ocular allergy with keratoconjunctivitis, with an ongoing atopic dermatitis, it is atopic keratoconjunctivitis in children. And so this is important because the prognosis is different, because we know that vernal just stop at the adolescence and the atopic just go for all the life. So this is an important point to underline and to know this is a specific pathology of the childhood also.
Could you see this in the absence of atopic dermatitis with other potential atopic symptoms?
Could be only with atopic symptoms, but usually atopic dermatitis is present with the crisis of the keratoconjunctivitis. So what is important is just to look out, because sometimes you cannot see exactly what they have. So you have to have a dermatologic examination for that and to find out more symptoms.
Atopic pediatric patients are extremely difficult to treat in the first place. How do you go about planning a treatment plan?
This is very important because it's severe, it's a quality of life for the children, and it's also very difficult for the parents. So it's important to talk with the parents and to explain the disease. And also we have a treatment which is near, of course, that which is done for the vernal keratoconjunctivitis. I mean, it's important to have ocular washing, because the ocular washing can take off the allergen and take off also the inflammatory elements, and to plan, of course, some anti-allergic like antihistamines or mast cell stabilizers, and preferably it's important to have without preservative. So preservative-free is really very important also. And it depends also on the severity grade of the disease. And sometimes we must go to more important treatment for that.
What would that amount to? What happens if your standard antihistamines just aren't doing the trick?
Okay, that's important because we sometimes go to steroids, and we know that steroids are give complications, and sometimes can be a blindness complication. So this is very important to have sparing treatments for that. And today I think the more important treatment for it is cyclosporine, and it's a very good treatment and give good effects and good results.
That's given in drops?
That's given in drops. We have seen today that it could be done like a systemic treatment, but it's of course for extreme cases. And it's very, very unusual to give that in systemic treatment. But For atopic keratoconjunctivitis, lower dosage of cyclosporine works quite well, and in vernal, usually we need a higher dosage. That's sometimes a difference, and also because sometimes you need to have a very long treatment because these children get in adults, and so they still need treatment.
I'm not sure if it's indicated in children. Have you created an algorithm to determine the right dose for the right age or weight and so on?
Well, at the time, we don't have exactly the possibility to prescribe, but in probably soon we will have a product on the market with a good indication of VKC, and so probably will be adapted also with AKC. But at the time we are doing the preparation in our hospital, University Hospital make the preparation, and it could be 0.05 to 2%. It depends on severity, and for 1 time a day or until 4 times a day. So really it depends if the keratoconjunctivitis is severe and how is the quality of life of the child, and so all of these must be evaluated, and so we go to the good treatment. But for sure, the more important is to explain to the parents that a sparing steroid treatment is essential because there could be complication with that.
So would the cyclosporin be a seasonal based? Just when you're expecting the worst symptoms, or are these patients always allergic?
We try to get it seasonal, but sometimes season is very wide because it depends on the allergen. And so, of course, if it's pollens, it's quite easy because we know about the period. But if it's like dust mites, could be longer, and so the season could be really longer. And so we try to do our best to at least decrease cyclosporin if needed.
Are you usually working with a pediatrician in these cases? I mean, with an atopic patient, they have so much going on. You coordinating coverage?
Yes, we do. That's a good point also. We do that also with allergologists. We do that with pediatrics and pediatricians also. And sometimes the workup is very important to find out if there is a specific allergen. And we have seen also that alimentary allergen can be found. And if we find the allergen, we can go to desensitization and immunotherapy sublingual.
Very interesting. Thank you so much.
So it's a pleasure.
Thank you for joining us. For more information on this topic and related topics, please visit us at eurotimes.org.